Hello, this is James Tcheng. For the next 20-25 minutes or so, what I would like to chat with you about is hemodynamic support, specifically mechanical devices that can provide hemodynamic support. I'm going to spend most of my time talking about intra-aortic balloon pump counterpulsation, or IABP, and really just mention Impella, Tandem heart, ECMO, etc. at the very end of this discussion. Hopefully this will provide you enough information to know what you should do about making a decision to request an intra-aortic balloon pump to be placed, what you need to do to manage patients who have an intra-aortic balloon pump, and to also think about, or to at least understand, what the opportunities are with the other types of devices, what their indications and contraindications might be. The first place to start off with thinking about mechanical circulatory support is, what are we trying to accomplish? In order to understand what it is we're trying to accomplish, you have to understand a little bit of physiology of the heart. This is Physiology 101, that really in terms of the heart, you have two things that need to be balanced. There's the supply of blood in a normal situation. That supply is pretty much auto-regulated. In fact, blood pressure changes don't really substantially affect coronary blood flow. In pathologic conditions, however, blood flow can become dependent upon diastolic pressure, and so one of the targets that we're going to talk about is how to augment diastolic pressure. Once autoregulatory responses are exhausted, that is, they've maxed out, then the question becomes, how do you get blood to the heart? The second part of thinking about the physiology of the heart vis-a-vis mechanical circulatory support is myocardial oxygen demand, how much oxygen the heart needs to work. The oxygen demand is classically defined as heart rate times stroke volume, or cardiac output. But in fact, the O2 consumption, the demand, is more dependent upon wall stress, where wall stress is dependent upon the pressure, the volume, and the stress itself, the, if you will, the tension that's placed upon the wall because of the work that the wall is doing. And Laplace's law that describes this relationship is shown in the lower right-hand corner of this slide. The first of the mechanical circulatory devices to be developed is the intra-aortic balloon pump. It was developed in the 1960s, so relatively old by today's standards, yet it is still the one type of device that's most commonly used, probably because it is the lowest profile, it's the easiest, fastest thing to put in, and it's basically ubiquitous. It's available in every hospital for circulatory support. It works primarily by supporting the left ventricle via mechanical counterpulsation of blood in the aorta. So there's an effect during both systole as well as during diastole, and I'll show you those effects in a few moments. During diastole, in the upper portion, I hope you can see what's happening in the pictorial on the left-hand side is that the balloon is inflated. So during diastole, there's augmentation of the diastolic pressure. The pressure is driven up. And by increasing the pressure during diastole, you increase coronary perfusion, and therefore you're increasing the supply of oxygen to the myocardium. With systole, in the lower left-hand corner, you can see that the balloon is deflated. By deflating the balloon, concomitant with systole, what you're doing is you're reducing the afterload of the aorta and the central circulation in terms of how much pressure is being applied against that aortic valve. In other words, you're almost sucking the blood out of the heart by causing the balloon to decompress or to deflate during systole. This reduces cardiac work. The heart doesn't have to work as hard to push the blood out, and therefore reduces myocardial oxygen demand. And oh yeah, by the way, it also augments forward cardiac output to the heart and to the great organs. One of the most important things that I can show you that should help you understand what's going on is a classic or a typical normal inflation deflation timing pressure tracing of a patient who has a balloon pump in. This one happens to be set at 2:1, so you can see what is going on both with and without a balloon pump. So if you look on the very far left-hand side, let me see if I can get my arrow to come over here. This is systole. This is your typical systole. And then at the dicrotic notch right there, the balloon inflates, excuse me, the balloon inflates as the aortic valve closes. And you can see what happens here then is that you generate more pressure during diastole. With diastole, with the end of diastole, the balloon now starts to deflate as systole occurs, leaving you to an augmented and a lowering of your end diastolic pressure. And then in fact, what happens if you don't inflate the balloon is that you have an assisted peak systolic pressure that is lower than your normal peak systolic pressure because you had augmentation of your forward pressure during diastole. So if you look and ask the question, well, what does this actually accomplish in terms of your blood flow? You have a decrease in your systolic blood pressure by somewhere in the neighborhood of 15 to 20%. Yes, an intra-aortic balloon pump actually decreases the normal systolic blood pressure because you're augmenting pressure elsewhere. You also increase your diastolic blood pressure. Again, remember, you see that waveform by about 30% or sometimes even a little bit more than that. This results in an overall mean arterial pressure increase, and it's really the mean arterial pressure that then determines forward cardiac flow through the vessels such as the coronary artery bed. You have a reduction in heart rate by somewhere in the neighborhood of 10 to 20%, reduction in wedge by 10 to 20%, and an increase in your cardiac output by 15 to 20%. So now let's move on to think about where you would use a balloon pump, and obviously importantly, where would you not use a balloon pump? The classic indications for intra-aortic balloon pump implantation is support of a patient who's in cardiogenic shock. The most typical one that you see day in and day out is a patient who comes in with a big MI where there's pump failure, or where you have mechanical complications of that MI, such as mitral regurgitation, ventricular septal defects, where you're really trying to unload the heart so that the blood doesn't go, quote unquote, the wrong way. It's used sometimes in the perioperative situation, especially with bypass surgery, whereas a patient's coming off pump, if you have a relatively stunned heart, you really need to augment that forward cardiac performance, and a balloon pump is oftentimes put in there. Another classic indication where we use balloon pumps is when patients are literally kind of dying from systolic heart failure. Heart failure with a reduced ejection fraction. You can augment the forward cardiac output. Now the indications where house officers could really take advantage of balloon pumps happen to be the last two, where you don't always think about this, but if you can unload the heart, you can reduce the workload of the heart, you can actually treat unstable angina, especially in a patient who has refractory intractable angina after presenting with either an unstable angina picture or a non-STEMI type of picture. And it's also very useful in patients who have intractable ventricular arrhythmias, at least as a bridge towards definitive therapy for, in the first case, getting the patient to the cath lab and doing revascularization. In the second case, addressing their ventricular arrhythmia with electrophysiology and or pharmacologic therapy. What are the absolute contraindications? If you have bad AI and you're increasing the pressure during diastole, that will drive more blood into the LV. Obviously, that's not a good thing. And if you have an active aortic dissection, you don't want to rip the aorta anymore by increasing the pressure in diastole. There are also some relative contraindications that you need to be aware of. If you don't know what's wrong with the patient and they're in shock, that's not an indication for a balloon pump. You really need to figure out what's wrong with the patient and treat their primary problem, not treat just the shock. You need to address the etiology, the reasons for the shock. Abdominal aortic aneurysms that have not been resected or otherwise stented, isolated, etc. That's a relative contraindication. If you have uncontrolled bleeding with an intra-aortic balloon pump in place, you need to anticoagulate that patient, or the balloon pump itself could thrombose. So if you have an uncontrolled bleeding diathesis, you really don't want to be putting a balloon pump in. And one of the things that's a little bit difficult to conceptualize, but this bridge to nowhere concept is at least needs to be mentioned. If you don't have an endpoint, if you don't have something that you're going to do with that patient or for that patient to get them out of trouble, it really makes no sense to put in a balloon pump either. All right, let me finish up then with walking you through things that you need to know about balloon pumps, things that, if you will, go bump in the night. So what are the things that need to be troubleshot with balloon pumps? There's several of them that need to have a fairly high degree of attention on somewhere between an hourly to at least a daily basis. Position of the balloon tip, augmentation, the waveform itself, and some mechanical complications. So I want to take a look at each one of these to make sure you understand what it is that you need to know. The first one is about the balloon pump tip. The tip of the balloon should be just distal, that means about 1 centimeter or so, to the takeoff of the left subclavian. Pictures are a little bit grainy on the left-hand side, but I think you can see the takeoff of the left subclavian and that the tip is distal to that. Now, as you think about your patients, why would that balloon pump move? Well, the balloon pump might move because they're bending their leg. And with the bending of the leg, you can drive, the balloon pump up in ways that you actually become unsafe, either by potentially lacerating the aorta or jamming itself into the left subclavian. So one of the recommendations is for you to get a chest x-ray basically every day to make sure that the balloon pump is not too far distal, not too far pushed into the aorta. The base of the aortic knob is probably the safest position. You know, take a look on your chest x-ray, see the aortic knob. 1 to 2 centimeters is about here, but if you just put it at the base of the aortic knob, that's about as safe a position as you can get. What about timing? Timing with the current modern consoles is usually not an issue. The new consoles are very good at figuring out, based upon the ECG signal, when to inflate and when to deflate that balloon. The consoles, though, even as good as they are, get a little confused sometimes when there's a pacemaker in place, when the arterial waveform is not being transduced that well, or if the patient has no forward cardiac output, like, for example, patients in VF, you're just trying to get some forward cardiac output so that you can keep working. You need to be able to understand what it is you're trying to accomplish vis-a-vis timing. What you're trying to accomplish is maximum augmentation. Here's a nice display of a typical waveform where the blue on the bottom is what's going on with the balloon pump itself. The red is the transduction of the patient's hemodynamics, and you can see the first little blip there. The first wave is systole, then you hit the dicrotic notch, and then you have augmentation during diastole from the balloon. That's the ideal, and with that, the diastolic augmentation typically is at least 10 millimeters of mercury higher than normal systole. In fact, as I mentioned before, and I'll mention it again, systolic blood pressure may actually fall as a result of putting a balloon pump in. Where you get into trouble is when you don't see that augmentation. And so the question is, how do you check on the timing? How do you determine whether or not the balloon pump console is doing the right thing? Well, the easiest way is to set this on 1 to 2 augmentation and then look to make sure that the beginning of the balloon pump inflation is right there at the dicrotic notch. And you can do this, and you can see there's a kind of a sharp V at that point of inflation. If you're inflating too early, the waveform characteristic is that the V is displaced so that it's earlier than the dicrotic notch. You can see in the upper left-hand figure there's the dicrotic notch without a balloon pump firing. The next beat, you can see that the timing of diastolic augmentation, let me see if I can do this with my pointer, is a little bit early. You never even see that dicrotic notch. Okay, so that means it's too early, and that will allow you or not allow you to have maximal augmentation. If you have late inflation, okay, what will happen is your aortic valve closes, you have the dicrotic notch right there, and you can see there's a dip down here. And what happens again is that you don't have maximal diastolic augmentation with the balloon pump. So the first thing to do is look at the point of inflation. When is the balloon being blown up? From a deflation standpoint, again, you don't want it to be either too early or too late. If it's too early, what you again have is suboptimal diastolic augmentation, because this peak never can get as high as it could is if deflation were more properly pushed out to where it should be. If you have delayed deflation, you really end up with suboptimal afterload reduction, as is shown here. This is with the deflation of the balloon pushed out way into the start of systole, and because there is the pushing out of this, you actually don't have augmentation of the reduction in afterload. All right, let's turn then to mechanical issues. What are the other things that you need to look for in terms of troubleshooting balloon pumps? The first one is a change in the waveform, so that you don't see that nice waveform that you would expect from an intra-aortic balloon pump that's working properly. It may just be the waveform. It does not necessarily mean that it's the balloon. If you have a kink in the shaft, most of the time this will round out the top of the pressure waveform. Easy solution, see if you can straighten out the patient so that you reduce that kink. Thrombosis is a little bit more difficult of a problem to manage. That means you're having clots form in the channel, in that pressure channel. Now these pressure channels, the center channel of that balloon pump, really should be continuously irrigated. So if you're seeing that there's a diminished waveform, that is, the whole waveform starts to look compressed, ask the nurses to both aspirate and then flush through to see if that will clear up the problem. Leakage, if you see blood in the helium line, that means that you've got a hole in that balloon. You don't want to be injecting helium into that patient, and so that's an indication to turn off the balloon pump right then and there, call for a replacement, etc. You may get into problems with the console, setting the alarms, etc. These consoles are fairly reliable, but it is something, it's a electromechanical device, so you should be able to at least understand whether or not it's giving you back the right information. A low helium alarm, actually when you see the low helium alarm, you actually have at least a week before you run out of helium, so that's typically not an issue. We do have a service that will come to your aid, come to your rescue, and it's 970 pump. You can also call the interventional cath fellow to come and help you assist if there are mechanical issues that you detect. From a patient management standpoint, these are the things that you ought to be looking at. You should check the waveform hourly to make sure that the balloon pump is doing what you hope it should be doing. Anticoagulation is important. I mentioned this before. I just want to emphasize it again. A balloon pump that is not anticoagulated eventually, not quickly, but eventually may thrombose. So heparin anticoagulation for the duration of a balloon pump is indicated. You should check the lower limb pulses every 2 hours. Make sure that there's no obstruction of arterial flow into the lower extremity. If there is a lack of pulse, if the leg is turning white or turning blue, again, you need to get the cath lab staff involved to think about removing that and putting the balloon pump in on a different site. Prophylactic antibiotics are not indicated. You do not need to put that patient on Ancef or any time of the cefazolins. You do need to maintain relative sterility at the site. The unit is self-contained, so even if you need to move the balloon back and forth, there's a sleeve that allows you to maintain sterility. I mentioned before, want to mention again, please try to restrict hip flexion movement especially, and keep the head of the bed elevated to no more than 30 degrees. A chest x-ray daily, and then labs daily. A CBC complete with a platelet count. Make sure you haven't introduced heparin-induced thrombocytopenia, that you're in the reference range that's between 50 and 70 seconds with your APTT. Creatinine BUN, why do you need to follow that? Well, if you have a balloon that's partially obstructive of a renal artery, that can get you into trouble as well. Last couple of slides, what do the guidelines say? Where should we be using a balloon pump? Where should you be thinking about using a balloon pump? In the STEMI guidelines, it's for cardiogenic shock patients who don't recover quickly after revascularization and pharmacotherapy. That's going to be largely a decision of the cardiac cath lab. The other ones that are perhaps more useful are the 2A under the ESC guidelines when a patient is hemodynamically unstable or in cardiogenic shock due to mechanical complications that occur right there in front of your eyes. You can call for an intra-aortic balloon pump to be placed to improve that patient's stability. And then the last one I mentioned this before, but I want to emphasize it again. It's a great tool for managing patients who have refractory or even intractable ischemia after presentation, and also ventricular dysrhythmias, malignant ventricular dysrhythmias that you think is on the basis of ischemia. I did mention before at the very beginning that I would talk at least briefly about other devices. There's a whole plethora of devices that we have available. The intra-aortic balloon pump, as I mentioned, is the easiest, fastest one to get in. The limitations of the intra-aortic balloon pump I'll show you on the next slide, but the primary one is that although I've been espousing the virtues of this, it turns out that you don't really augment cardiac performance all that much. It's not until you are using devices like cardiopulmonary bypass, full cardiopulmonary bypass, the Tandem heart, the Impella, or even extracorporeal membrane oxygenation, complete circulation replacement, that you get to the range that you can support the patient completely. Which one of these do you need to know about? Well, my advice is if you are in a situation where you don't think a balloon pump is going to be enough, that's the time to actually get the cath lab involved, because all of these other devices really do require thoughtful thinking, a lot of thought and consideration, I should say, in terms of making a decision about which one to use. The Tandem heart requires a transatrial puncture, so you have to get a catheter from the right side over to the left atrium. That's where the blood is, if you will, returned. It's introduced after it's withdrawn from the venous side. The Impella is a catheter that goes up through the groin. You introduce it into the left ventricle. There's a pump that is housed right inside and across the aortic valve that can use bring blood forward. And then ECMO is an extracorporeal circulation device, which also creates oxygenated blood outside of the body. This is my last slide to try to give you a sense of where things should be used. The intra-aortic balloon pump, Impella, and Tandem heart are all useful in high-risk angioplasty situations and in shock, as I've mentioned. The transeptal puncture is required by the Tandem heart. You can see the fourth line down in terms of support. Unfortunately, a balloon pump is only going to push or augment your forward cardiac output somewhere in the neighborhood of maybe 15 to 20%. You do the calculation, that's about at max half a liter per minute. With the Impella, there's a 2.5 liter per minute device. There's actually a 5 liter per minute device. A Tandem heart can give you 4 to 5 liters per minute, and ECMO can actually completely support a patient through a period when they have no forward cardiac output. So I hope this has been a useful introduction for you to think about when an intra-aortic balloon pump might be indicated, how to go about managing a patient, how to go about managing the pump, when to understand you're in over your head and you need to call for assistance, when to understand that there are things that you can do to especially adjust the augmentation to maximize, or just the timing to maximize the augmentation on an intra-aortic balloon pump. Thank you very much for your attention.